like in for a pediatric age group, it is called FLACC, F-L-A-C-C. So how do you do it? So make it very simple, don't complicate it. So it has 0, 1, 2. That is what we come to a conclusion how severe it is. So the child, when it is in pain, how it will be expression, or the child is smiling, that means it is 0, child is normal. Or occasionally child is not interested showing, it's a kind of withdrawn, it's about to cry, that kind of things, you always call it looking at the face, you can even give number as 1. Then child is kind of a grieving, you have to look at the face and decide. I'm sure all of us by now, by looking at the child face, whether the child is having pain or child is about to cry. So think of the first level is your child's face. So because we all have a tendency to forget, that is all I am trying to kind of putting it very simple. So the face is F. Next is L. So maybe I'll connect one with the other so that you can remember. First, when you look at a human being, you will look at the face. You can remember like that. Next, of course, you will have to think of the legs. So normal position, relax, or if the child is really in pain, uneasy, restless, tense. So if you can remember this face, face, leg, activity, cry, and consolability, that much if you can remember, I'm sure rest of the things with your experience, you will be able to monitor. So what is that leg? If it is severe pain, child is crying, kicking, or leg drawn up, see, that is what the child keeps crying. When either the child will start kicking, the leg will be drawn towards the body. So this is what number 2 you can think of when it comes to legs. So what is the child's activity? You all know when the child is having pain, the child will not be, moving around. Child will be so tensed. So one more thing is child will be rigid and it's kind of a jerk you will find. So that is what it is all about, activity. So remember little bit about face. Then you think of legs. Then you think of the activity, very important. Then, of course, the child's cry. So the cry part is very important because it will reveal a lot of things when the child is in a kind of a pain. So child is occasionally complaining, or the child is not in a stage to complain, and our child is steadily crying. You can always think of 2. So first level, I want you to remember this FLACC, F-L-A-C-C, face, leg, activity, and cry. So what is it in all this? You can try to do something with the child. You put the child, take the child in hand, you put the child towards the chest. Lot of things you can comfort your child. But the 5th is consolability. That is what I'm trying to do. Consolability is, can you console the child? Can you put the child in the chest? Will the child become quiet? That is always a thing where you understand the child could be made calm. You can console your child. But there is some difficulty where the child becomes unconsolable. You cannot make the child. You cannot console the child at all. That means the pain is very severe. The child is not going to stop crying at all unless some intervention is done. So that is what it is about. Face, leg, activity, cry. Please remember, that's why to made it very simple. It is place. So you can decide, you can make it 0, 1, or 2. Sorry, next. Okay, so this is what I told you, Wong-Baker face. So as I told you, it's mainly for the pain scale. And it is Donna Wong and Connie Baker, these two people, because as a nurse, we should know this is two human beings' names given for this scale. So that is also, and of course, the rest of the things we have discussed. And please make it very clear, it is totally only 6 phases, and 1 is a normal, and 5, of course, is related to 1 to 10. Next. So there are 2 other aspects all of you should know. When it comes to pain, how do you assess the pain? The characteristic of the pain. So character, see, like I am a good person, I am a bad person. Again, we have a lot of confusion what is. So make it very simple. When you think of the character of the pain, this is one of the assessment which you will be doing when you do the pain, along with the rating. So I don't need to tell you, it's a stabbing pain, cutting pain, stinking pain, burning pain, boring pain, so much. So this is all character of a human being. If she is an angry person, she's a quiet person, she's a calm person, she's a short-tempered person. So combine these two, character of the patient's pain. This is what the character is. This is a shooting pain, throbbing pain. So this is all put together. As a nurse, you should know when you assess your pain, when it comes to assessment, you should know that it has to be one of the character, or it can be combination of 2 can be there. So this is what it is about, yeah, character. As a nurse, you should know this characteristic of pain. Next. Next. So 2 more important things as nurses. So we always have doubt about duration and frequency. So you can always think of one more thing I'll tell you. Sorry. There are 2 things. One is pain. Duration is how onset of pain. 1 o'clock the pain came, then the pain came at 2 o'clock or after 3 o'clock. So that is called the duration, the onset of duration. All of us should know. Once the pain comes, the duration is how much time it stayed with the patient. So that is very important. It's not only the labor patient which we are talking about. Every pain assessment, you should know how long the pain stayed. So how often the pain came, that is what the frequency. So when you assess the pain, you should know the characteristic, the duration, frequency, and with your scale, what is the rate. Next.
Okay.
So I have told you, so this is what the pain I'm just giving. Maybe in your unit, you will be using a different kind of thing. As I told you, the date and time, pain score, location, definitely you have to write. Characteristic of the pain, the frequency of the pain, of course, that part of it, education to the family is very important. So, yeah, next. Next. Okay, so this one thing I want all of you to understand, we are many of us are, before next. Yeah. So pain reassessment, please make it very clear, all of you. When a patient is complaining of pain, you go with your either one of your scale, you go and assess your patient, come to the conclusion, your rating is 8, whatever it is. Then you will go for a physical or chemical intervention, which I'm not going into that now. But when you will do the reassessment, see, early days, we were never reassessing our pain. Now it is mandatory. So if you are giving a patient an IV injection, after 15 minutes, you should go back and assess your pain and you should write back. That is what in that page, what I showed you. 10 a.m., you have assessed the pain, you have given some paracetamol injection, IV. You will immediately assess your patient after 15 minutes and you have to, so the rate was 8, After 15 minutes, you are in every shift, but if there is an intervention, again, same, if it is IM injection you have given, after 30 minutes, you should go and assess your patient. Again, that time it is 9, then what is your after IM injection? That you have to mention your score. Same with oral drug, after 60 minutes, you should go and do the reassessment because IV absorption is very fast, IM is moderate, oral is very slow. So that is what it is. As a nurse, you should know assessment of pain, intervention, and then reassessment. Okay, next. So we'll come to the last thing is fall assessment scale. Next. See, all of us have a doubt. Why do we check a fall assessment? See, why do okay, so the reason is when a patient is admitted, a patient is assigned to me. He's a 50-year-old man. I have no idea about this human being. So how do I take care of him? I have no idea. So that is what, is he having a tendency to fall? How do I come to a conclusion? That is why the fall risk assessment has come. Like similarly, the pain came, same thing, the fall also. So how do I come to a conclusion? So we have few parameters. So this scale is called, all of us, I'm sure most of you are aware, it is called Moore's fall scale. That is what it is, assessment scale. So it has a very few parameters. One is, how do I know? Mr. Murthy has come, admitted, and I'm just going, hello, Mr. Murthy, I want to assess your fall. How do I know? I will have to say history of falling. Any history, recent history or a past history, or often he is falling. It's one aspect. Yes, there is already a physical problem he has because of associated intense tension. So please, I want all of you to understand very clearly. Incontinence, see, I'll tell you, if you reach the age of 60, 65, or 70, there is always a tendency to pass. Even if you cough, you have a tendency to pass urine. So they don't want to wet the bed. They don't want to wet their dress. It is like a child feeling so bad for that elderly man. He has a tendency to rush to the toilet. So this is what a fall will happen. So he has an incontinence. So how do I take care? Vision problem, I don't need to explain to you. It's very important whether he's wearing a spectacles at home. Has he left and came? Can he walk without a specs? Very important. As a nurse, you will assess to prevent a fall when he is with you. Multiple medication, for example, antihypertensive drug, anticonvulsive, any sedation, all these are very important. And the patient having a orthostatic hypotension, definitely, they always have a tendency, even get up from the bed also, they can fall. So this all more scale made it very simple. So such feature here. So of course, many of the hospitals in India, it's not very common, but still there is a tendency of them having, if at all there is a thing, protocol, you have Of course, Kate, yes, our balance and you don't have a control on your own. So this all few things are put together. So when Mr. Murthy has come to me, admitted, and I am assigned to Mr. Murthy with these few parameters, conclusion, Mr. Murthy next to severity, mild risk of fall. Next. So this is what it is. So Moore's fall risk assessment scale is already given some rates. So same thing, whatever I have told you, the rating is given here. So what I need to do, I can always reflect the rate which is there on the right side and compare with my patient. I bring it on the left side, or I can write, or if it is not there, I can write 0, 0, 15, 13, 0, 20, 0, 10, 20. So let me rate my patients, and I'm sure all of you are doing it already. Then add all the points together, and then you come to the conclusion. Then you compare with the scale stating that my patient is moderate, mild, or severe. So same thing, whatever I have told you, it is all there in this same chart. Next. Next. Can you go to the next slide? Sure. Thank you. So this is what it is, but there are different areas. The scale, no, little the previous one. Yes, I want you to just see the bottom one. So when you, the next one. When I calculate, add all the score according to whatever I have studied from my patient. Next patient, low risk is 0 to 24. Is medium 25 to 45. I should understand that his risk of falling is medium rate. So I need to definitely take care of him very well when he's with me. I put the side railing, all bell, he should kind of take it to him. When he gets down from the bed, how will I help him? So this is what it's all about. But I come to a conclusion because I don't know anything about Mr. Murthy. At the time, 10 a.m., he got admitted. By 11 or 12 o'clock, after I do with the more, my patient, Mr. Murthy, is 25 to 44 is his score. So how do I take care of him? So this is what it's going to help us. So let us not use all the scale as a mandate, a mandatory thing. So make it, anyway, after this, I'll tell you one more important thing. As I told you, reassessment is very important. So when we all have always doubt. So combine it with the practically what is important. Don't go and read and buy hard things. Understand, when will I do a fall? As I told you, Mr. got admitted at 10 a.m. to my ward, and I am assigned as a nurse for Mr. Murthy. When I receive the patient on admission, I put it as a first my patient to know that is he mild, moderate, severe, chance of falling when he's going to be with me in the hospital. When do I do again an assessment? Receive the patient back to the unit. For example, say Mr. Murthy is 45 years old. He is going for a cardiac surgery, CABG, but on admission, he has no risk at all. That is on the day of admission. He is able to go to toilet. He is able to walk on his own, no problem. But The next day I'm preparing him and I'm sending him to war. So he is undergoing a major cardiac surgery. 3 days he stayed in the ICU. The same Mr. Murthy, 45-year-old man, is coming back to my ward after 3 days. So I am supposed to assess him again on the fall risk. So imagine he's going to be totally different. Mr. Murthy, he had 0 result. Now he has more than 45 risks. He cannot walk on his own. He cannot even stand him. Understand well. He had no risk 2 days back. But today when I receive him back, he is high risk for fall. That is what, when we receive a patient back to the unit, automatically you register all this in your brain so that you don't need to again look into it. It will come automatically to assessment. When do I do another reassessment? If I receive the patient back to the unit, every day once in the morning, that is the protocol, most of the hospital, every day morning, we can make it at 8 a.m. You will do an assessment. Then any patient started on any antihypertensive, I told you in the most fall risk assessment, anybody who has started an antihypertensive drug, please remember, because it can make a lot of difference in their walking, and suddenly they will get into a kind of giddiness, or suddenly the BP will go down because of drug. So all this, any antihypertensive, you have to. So for example, 8 a.m. I assess my patient, but doctor came and prescribed by 11 o'clock antihypertensive drug. After 1 hour, I will assess my patient again. Then patient started on any anti-convulsive drug. At least this much, if you all can remember. There are so many other things are there, but this will be good enough. So when fall assessment is one aspect, more fall risk assessment. Reassessment, it doesn't end reassessment, only will do the follow-up. So these all receiving the patient every day once in the morning. Don't have any doubt. Pain you will assess 3 shifts, but fall you don't need to assess 3 shifts. Once in the morning is good enough. But of course, if he's put on any antihypertensive or any anticonvulsive drugs, you have to assess after 1 hour or 2 hours after monitoring the patient. Then you have to do a fall risk assessment. That is very important, because that before that he would have been for risk for fall. But after starting an antihypertensive,
Ma'am, can you hear us? Hello? Ma'am, can you hear me? Ma'am, can you hear us? There is a video on the
Thank you, ma'am.
I think the session was almost completed. Yeah, ma'am, can you hear us?
Yeah, I can hear you.
Yes, ma'am. Yeah, so I have just stopped the screen slide, ma'am, and you can speak now, ma'am.
Yeah.
Yes, ma'am.
Can you hear?
Yes, you're audible, ma'am. Now you're audible, ma'am.
Hope
Your presentation was completed, ma'am. The presentation was
yes,
completed.
it is completed. Anybody has any question?
You have made it so clear, madam. There is no need to ask question, I think.
Okay, very Usha
It was
sir. Thank
yes,
you. Thank you.
Yes, ma'am. It's such a lucid presentation. It was so wonderfully presented, madam. It was very simple and very nice. We're lucky to have attended this. I have already told Ongol, Guntur, Vijayawada. I think most of them will be attending too. So I am in Tiruvuru. I have got my few staff here who are not on duty because we are very few only here.
Sure. I think there also Vijayawada also they are connecting. Guntur also Geeta.
Guntur and Ongol they are conducting in the conference hall.
Hi ma'am, this is Kirti ma'am from Ongol.
Hello.
My unit 40 nurses are attended ma'am for your session.
Very good.
Thank you so much ma'am for explaining these scales. It is very useful our nursing ma'am.
Anything you want, you let me know about the PPT. If I can share that also. You can continue the same with the classes. Huh?
Thank you, ma'am. Bye, ma'am.
Thank you, Usha.
Thank you so much, ma'am, for joining this and giving us this session. We will come back to you for the next session for this 1 hour. Thank you so much.
Anytime. Thank you. I should be thanking HSSC, Miss Ansu Verma and Miss Pooja and all the others. It's so wonderful. It went very well. We are so happy. Thank you very much. Thank you.
Thank you so much, ma'am. Thank you so much.
Bye.